All right, so just for a little bit of a break, I'll talk about Ethiopia for a minute. Actually, just to mention to you, and it puts survivorship into perspective a little bit, but there's 4 oncologists in Ethiopia, population of 80 million people. There's 3 oncologists in Uganda for a population of 35 million. So I have to say, it would almost be like as if Hartford Hospital, okay, was the only cancer center for the entire East Coast. I mean, it's a pretty amazing kind of concept. Anyways, just to share with you, there are some, for people that are interested, ASCO and ASH, but especially ASCO, which I'm involved in, does have a project where oncologists, oncology nurses, social workers are going to Africa, Honduras, Vietnam, and teaching oncology, because the goal is to have a workforce. So if any of you are interested, email me, call me, or catch me afterwards. I love to talk about it. So just changing the topic. Anyways, all right, let's talk about buy-in and pushback. Any of you can any of you relate to that topic? Well, maybe a little bit, okay. So what I wanted to say was that there are a lot of programs. A number of years ago, there were less, but the Connecticut Challenge program here at Yale was one of the first ones in the state, not the very first. Dana-Farber's had a program on the pediatric side for about 15 years, on the adult side for more like 7 or 8. And there are a lot of programs. Here's one from UNC and the Hutch and St. Charles Hospital. And though it's interesting, if you Google survivorship programs, you get a lot of events that people have sponsored, but you don't get quite as many programs. But there are a lot of programs. Now, anyone know what this is? This is window dressing. So, and I don't want you to leave here saying that, geez, one of the speakers said that survivorship is window dressing. But I will tell you, some programs, survivorship care is meaningful. My wife is a 2-time cancer survivor. And also, is anyone here a cancer survivor? Raise your hand if you would. Thank you. So by the way, good for all of you. But providing survivorship care is meaningful, is very meaningful and very important. But sometimes hospitals do it to check off the box, to say, well, we have a survivorship program. And I just share that with you. I don't think that's common, but I think if there's going to be a program, it should be with true endorsement from a hospital, a meaningful endorsement in a hospital or a facility saying, we think this is just as important as every other phase of cancer care. So I want to talk today about buy-in and pushback. I'm going to read some quotes, but really just portions of them because it's late in the day. Here's a woman named Kate saying, my visit to the survivorship clinic was wonderful. I felt that someone finally listened to me, finally. My husband and I have not had sex since my breast cancer diagnosis, and I kept hoping my oncologist would ask me about it. So here's a woman who came to the survivorship program, and someone asked her about it, and it really started quite a big conversation. And I very much agree with what Carrie just said, which is the care plan, and I'm probably not going to paraphrase it right, but a care plan can really just be a piece of paper, but ultimately what we really want is to document the wonderful services that are available. And so not every program can have a sexual health program attached to it, but ideally we'll have the resources for people. And then pushback. It's good to have your survivorship program. I'm providing this care already, so I'm supportive, but will not be referring patients. I mean, there's a lot of perspectives. Here's buy-in, a woman named Ashley. I was treated for Hodgkin's disease at age 22 with chemotherapy and radiation, and it seemed like ancient history to me. Sadly, my developing breast cancer is related to my radiation. Thank you for sending me for the MRI, which found it before a mammogram or breast exam could find it. And pushback, and by the way, these are random photographs, so these are not, this is a doctor named Corey, anyways, he's a wonderful man, he would not say this, but, so if you see him, don't tell him. Anyways, you and your staff are not experts in GU cancers, so I want to see my own patients for follow-up care. Again, just a different perspective. Buy-in. Cindy, I'm one of those people who likes as much information as possible. I can't say that I'm happy to have a risk of developing heart problems from my treatment. On the other hand, it does motivate me to get my blood pressure treated and to make exercise more of a priority. I'm more committed than you can imagine to prevention. I want to stick around. And Pushback. I have been practicing oncology for 20 years. I don't want your program to tell me what follow-up schedule or tests to order. And again, some of these are a little bit exaggerations, more on the Pushback side, but they are things that, you know, I've heard colleagues say in one form or another. And I think there's some of the barriers that we face in trying to get programs going. Buy-in. I've only got a few more of these. I had an allogeneic transplant in 2002. In the past 2 years, I've lost weight and muscle mass and look quite wimpy. No libido or erection, no energy, quite blah. I started testosterone as a gel after you told me about my hormone levels, and I'm feeling about 80% better. Thank you. And by the way, this one's a true story. This was a fellow that I took care of many years ago, so the name in the picture has changed, but had a autologous bone marrow transplant for CLL, which we're really not doing anymore. But anyways, as I followed Barry over a number of years, who's really a friend in many ways, really started losing weight and just didn't look like the same guy, and et cetera. Turns out his testosterone level was so horribly low, and replacing testosterone made a big difference. Pushback. My patients want to see me. And at the end, you know, the doctor says, well, to be honest, it's part of how I make a living, is seeing patients. All right, I think I'm going to skip ahead a little bit. So I did do a survey of the directors of the Lance Armstrong programs. There's 7 centers of excellence, and there were about 14 directors, so altogether about 2 at each center and other members of their board. And I asked a number of questions, so let me share these with you. How would you rate the buy-in for your program? 1 was significantly below what I would expect, and 5 was very, very good. And here's where it came out. About 53% were a 3, sort of right in the middle. 23% were a 2. So about 70, well, if we go 3 and below, 76, about 80% of the directors of these programs said it was average or below average. How would you rate the success of your program? And again, 30 and 38 is 68%, and 23 is almost 90%. We're saying about a 3 or below. And let me just ask this group the same question. How many of you would say, in terms of the success of your program, that you were in the 4 or 5 range? And how many would say 3 or below? And how many would say nothing at this hour? Okay. Anyways, the point is, you know, that people, we as providers, I think, want to develop wonderful programs, and they're needed, and they serve a very significant role. But it's hard to get in the world of high technology and a lot of tests and lab results, et cetera. It's hard to get often the kind of endorsement, buy-in, tremendous enthusiasm that programs deserve. Okay. How busy are survivorship programs, I asked. And again, at this point in time, most of the programs said 3 or below. Now, it is possible to grow the volume of a survivorship program. This was from Dana-Farber, where I worked for the last 3 years, and anyways. But the number of visits, or number of patient visits seen in 2007 was about 600, and then about 750, and 1,600, and finally up to about 3,000. So it is possible to be seeing a lot of patients, providing a lot of good care. Though I would share with you also, one of the things to figure out in advance is to come up with the leadership of your hospitals, your institutions. What is the metric of success? Is it the volume? Is it the scope of the program? Is it treatment summaries? Those are all different. Let's talk about pushback. And sometimes, and I've heard this at some of the conferences that I've spoken at, but you know, we receive funding in space, we've hired clinicians, where are the patients? You know? Someone was saying to me at a meeting this past summer, my chief asked me to start a survivorship program. I've met with the disease centers. We have a great plan, but not many patients. And other people say it's slow going. So sometimes, and oftentimes the pushback part is shown in terms of referrals. All right. So I asked these same center directors, and again, I would ask you to think about these same issues for your own programs. Is the most significant problem for survivorship programs lack of awareness, apathy, belief that survivors already receive survivorship care, the desire for oncologists to hold on to their patients? And as you see, at least from this small sample, it was the desire to hold on to patients. And how significant is lack of awareness about survivorship? That was actually pretty common. In other words, it's not something, and I'm going to show you some information, some data later, about why this may be the case, that lack of awareness by clinicians is part of the problem. Apathy, very significant problem. Belief that survivors already receive survivorship care was less common. Desire to hold on to their patients, very common. And I'm going through this sort of quickly, but just trying to identify some of the things. Antagonism. So I did have one, I'll never forget it, but one of the nurse practitioners at Yale came over to me and said, well, Dr. Jones wants your nutritionist, who's over there, Maura, who's wonderful, to see Mr. Smith, but not anyone else. So, I mean, as if there'd be some harm coming to the patient by seeing the social worker in the program or the exercise trainer. But I just to share with you, so on occasion there is some sort of some real pushback, but most of the time it was lack of awareness, some apathy, not being on the radar screen, more so than it being a real antagonism. So there are a lot of again, the holding on was a big theme. There were some other issues. Lack of outcomes data. We're pretty data driven in our field, and it was very good that Carrie brought up this article just published, but there's very few articles that really show that this makes a difference. Some of the other comments were weak or apathetic more than weak leadership. Lack of awareness of survivorship issues, holding on to patients. The administration or other clinicians don't see the value of a comprehensive assessment of other health needs beyond cancer surveillance. So I think in a sense it's not keeping in mind that most of survivorship is not acute. It's not treatment, diagnosis and treatment. If we look at the population of cancer survivors out there right now, most of them have been alive, 60% are more than 10 years out. So really the rest of their health care becomes quite relevant. And then finally, short-sightedness on an institution's role and thinking more beyond traditional services. Also, nuts and bolts issues are important. Having personnel to complete the treatment summaries, reimbursement, staffing and human resource issues, and finally funding. And so again, this is part of the reason that programs sometimes have a hard time growing are these, and sometimes it's nuts and bolts, and they're all related. I did do a separate survey on the word cure. This was sort of interesting. And I asked 100 oncologists at Dana-Farber, are patients hesitant to say they're cured? About 46% said yes. Are you hesitant to tell patients they're cured? 76%. And then I also asked a different question. I gave 3 case scenarios of patients who were 20 years out from cancer. One had Hodgkin's disease, and one had non-Hodgkin's lymphoma, and one had colon cancer. And I said, does he or she need to see an oncologist each year? And 20 to 30% said yes, 20 years out. And I'm not saying these are wrong, but I'm just trying to point them out as really sort of issues. If someone is never cured of cancer, then they would need to continue to be seen in a cancer center. And there may not be a role, at least traditionally, for survivorship care. So again, this may be contributing to some of the issues we see about referral. All right, what's this? It's a radar screen, exactly. But as I wanted to show the window dressing earlier. I think this is another big issue too. But but the question is why? Why is survivorship not on the radar screen when clinicians are seeing patients? So I looked at a week in April of 2010 at Dana-Farber, and we randomly chose, there were 383 visits analyzed. And of that, 243 of these patients were actively receiving treatment. But what I really wanted to show is, and it's down toward the bottom, 3% of the visits were for patients 6 to 10 years out, and 1% of the visits were for patients more than 10 years out. So 4% of the visits during that week in April were for long-term survivors. And I think that is part of the reason it's not on the radar screen. I mean, most oncologists will say, yes, I want to follow my patients. I'm following my patients long-term. But actually, as a percentage of the time spent or of the visits, it's actually pretty small. And the other thing I asked was, by analyzing these charts, how many of the patients had no late or long-term effects, at least documented in the chart? And it's the majority at 5 to 10 years. Well, at 1 to 5 years, it was 103 out of 125 had no problems. 5 to 10 years, 101 out of 125. And greater than 10 years, again, it was still the majority. So most of us clinicians, at least at a comprehensive cancer center, NCI designated, are not seeing a lot of long-term survivors. And the ones that we're seeing are doing, for the most part, are doing pretty well. The late and long-term effects they had were fairly mild. Hypothyroidism, could be problems with, radiation changes on the skin. It could be some neuropathy, but they were not large and very severe and very major late long-term problems. And of the 85, let me just go back to that number at the bottom. Again, here were some of them. Cardiac was 2. And so just to mention, that's 2 out of 125 patients who were 6 or more years out, 6 to 10 years out, had a cardiac problem. So that's less than 2%. So again, think of a clinician not seeing many people 6 or more years out, and of the ones they're seeing, 2% of those have cardiac problems. And so it's not surprising that cardiac issues for long-term survivors is not as much on the radar screen. So I just mentioned it's not that anyone is ignoring it, or they're not thinking about it, or they're bad doctors, or they're bad nurse practitioners, or they're, it's that really these are not coming up quite as commonly as we think they are. This was at greater than 10 years. Now, cardiovascular was 6. So 6 out of 125 is about, it's about 5%. Now, some of that is patients who are old. Cancer survivors are older in this group. Some of it may be from normal aging. Musculoskeletal, 9. Hypothyroid, 12. 12 out of 120 is about 10%. So just to point out that one clinician in their clinical experience is not seeing this every day. And clinicians often will say, I do that already. I do survivorship. We don't need a survivorship clinic. Again, I do that. Carrie talked about, and I've really actually learned a lot just from her study that she did with the LAF and the approach to it, which is, again, 4 major services of survivorship care. This has been very helpful to me in terms of thinking, what do we do in survivorship? There's surveillance. And for the patients who were 6 to 10 years out, 100% of the visits had some surveillance. Prevention. Prevention is saying, essentially it's saying, I don't want you to get cancer again. And part of the way to do that is to eat well and to exercise and other health behaviors. And that was about 25% 25% of the visits that I looked at had some prevention component. 12% had an intervention component, in other words, dealing with some later long-term problem. And coordination of care was only 7%. And so it is true when oncologists say, I do survivorship care, they do. They're doing 100% of the time there is some surveillance. But the other services, which is what I think that we provide, are generally not getting done. And so I guess I encourage you also to think when people say to you, when other clinicians say to you, and hopefully they will ask you, why do we need a survivorship program? You could say, well, we do surveillance. And they're probably going to say, well, I do that already. But the other way to look at it is to say, our emphasis is on prevention of second cancers. We want to do intervention in terms of late and long-term effects, and we really want to focus on coordination of care. I mean, that would be another approach. This is at greater than 10 years. 13% of the visits had some prevention element. 22% had some intervention, and 11% had some coordination. But again, I have to say, well, for me personally, the prevention issue, I think is actually pretty intriguing. You've heard it so many times today, there are 12 million cancer survivors. And unfortunately, a significant portion, is probably about 16 to 20%, will develop another cancer. If we could impact on that, that would be terrific. So I'll summarize in a few minutes, but suggestions. I think Carrie mentioned this and some of the other speakers. You can't be everything to everyone. And so choose when you want to have an impact. What part of survivorship? Is it going to be a transition when people just finish their treatment? Is it going to be for the longest term survivors? Pick a place. Again, often at transition at the end of active surveillance, let's say 5 years, or when discharged, or some point in between. This is an article that I wrote called Seasons of Survivorship, which is not a term that I made up, but acute survivorship is during active treatment, transition, extended survivorship is surveillance, and then finally permanent survivorship. And again, you might say as a program, we can't do all of this, but we're going to be really good at focusing on second cancers and secondary cancers. Or we're really going to focus on patients with later long-term problems. And anyone here know what an elevator speech is? Raise your hand if you do. Okay, all right. An elevator speech is, Carrie, how would you describe an elevator speech? Exactly. Get your point across in 10 seconds or less. It's riding up on the elevator, hopefully of a fairly tall building, and getting your point across. And so I think, again, if I gave when I first started at Dana-Farber, I gave a talk on our survivorship program, and there's a pretty famous guy, George Canellis, and he stood up, and essentially his question is, what is survivorship? I mean, his point was, what do you do? I mean, be practical. I mean, tell us exactly what service you offer. So pick the places you want to have impact. Who do you want to serve? Do you want to serve breast cancer survivors, women as cancer survivors, survivors with higher needs, men? Make a choice, when and who. I wrote the word diversify here just to remind me, but you may choose, we want to do clinical care and research. And clinical care is our priority, and we want to do a small amount of research on breast cancer survivorship. Or we're really here, we're not going to provide clinical care. We're not going to have a nursing staff and an NP and a physician. We're here to make sure every single patient learns something about survivorship. And so we're going to provide information. We're a virtual clinic. There's nothing wrong with that. That's a good approach. Or we're here as a research program. But again, try to make some choices and maybe choose one from the top and one element from the bottom. Optimize buy-in. Oftentimes buy-in comes from needing to decompress a practice versus thinking the service is really an opportunity for the patient. And so for the hospital you're at, it's possible that a program would say, our clinic is so busy, we need you to see long-term patients. Does anyone have that situation? Okay. But that's something we sometimes heard at the comprehensive centers. We've worked with the medical oncologist to view the survivors clinic as a routine place for patients to go after they've reached 5 years. So the other thing to think about is, again, try to build survivorship into the routine of the practice. Turn critics into champions. Identify champions in your practice, then get them involved and engaged. Some of the other suggestions from the survey that I did is appoint mid-level providers and people that are champions to subcommittees, develop incentives for their time that they spend. Share your successes. And in the same way I shared with you some quotes today and some stories, I think that's often sometimes the very best way to advertise your program, which is quotes and pictures and again, clinical stories, just like we do when we're talking about lung cancer or colon cancer or cancer, and not talking about cancer survivors. And one of the people that I surveyed had interesting comments. Survivorship is too willing to accept what we are doing is right, but we're failing to prove it to others. And again, what that talks about is the value of research. They can be small studies and sharing the results. Have a business plan. When you go to your hospital leadership, have some kind of plan that makes it clear you're not going to be seeing 3,000 patients, every single patient your first year. It may take you 10 years to do it, and it's not going to be profitable, okay, at least initially. But there may be some downstream revenue and downstream benefits, and certainly benefits to the patient. Identify barriers. And I wrote here, or this was a quote, "The barrier of patient reluctance to transfer care still remains, but we're working hard to overcome this by having the medical oncologist introduce the concept of the survivorship clinic very early on in the follow-up course." And if you can get that much buy-in to have the oncologist bring it up early, that would be terrific. Other suggestions: pilot studies, develop an elevator speech, and I think Carrie said earlier, don't let perfect be the enemy of the good. And finally, I want to share, this is the book that's coming out November 30th. I'm advertising, but Mary McCabe wrote in there, and Dr. Andy Salner, and Carrie Stricker, and I think and many others. But it's all about the practical issues of cancer survivorship care. And finally, I guess that's my last slide. So thank you.